substance abuse program. And I have been here for a little over a year. I have over 20 years of experience in the mental health and substance abuse field as a licensed addictions counselor and a licensed professional clinical counselor. Majority of my work is with Native American people. And I have been with the Mental Health TTC and Addiction Technology Transfer Center since 2019, doing various webinars on various mental health and substance abuse topics. Most of my work centers around addiction work, and in addition to the addiction work that I've been doing, my experience has led me to focus on a lot of work that led me to seek certification as a trauma specialist, because almost everyone that seeks substance abuse services has been through some sort of trauma, as have several people throughout Indian country. Today's presentation is on person-centered care. And one of the reasons I decided to do a presentation on this topic is I just recently finished a CARF accreditation review. And I don't know how many of you out there are working for agencies that have CARF accreditation or are seeking CARF accreditation for your agency. And a part of the CARF accreditation process requires your program to provide person-centered care to the patients that seek services there. And my staff, I supervise 2 clinical social workers. I have 2 counselors, 2 trainees, 1 intern in my department. And Montana has a different process for licensing people. So my counselor trainees, they actually have a different, every state varies on their licensure. So I have some counselors that don't have some background. So I provide a lot of training to my staff myself, and it also gives me the opportunity to present it here as well. So today we're going to cover person-centered therapy. And thank you all for taking time out of your busy schedules to be here today. And we'll get started with the slides. Okay, just a brief overview of the history. This originated by Carl Rogers in the 1940s. And it also expanded a bit in the 50s and 60s with the humanistic revolution. Rogers was one that challenged the belief that clients can't understand and resolve their own problems with direct help from experts. So his challenge was that, yes, we can help these people. He questioned focus on the problems rather than on the people in the therapy. So that's what this person-centered approach operates from. Go to the next slide. The definition of person-centered therapy, also known as client-centered, non-directive. I've read patient-centered or Rogerian therapy, is an approach to counseling that places much of the responsibility for the treatment on the client, with the therapist taking a non-directive role. So I often tell my staff, when you're working too hard, something's wrong there. They should be doing the work. You're just there to guide them along and offer them support. Go to the next slide. The objective of therapy is to resolve the incongruence of the clients, to help them accept and be themselves. So this incongruence is sometimes, I've often referred to it as a mask we might wear in public, especially with people that are working with substance abuse problems. And sometimes it depends on the environment that you grew up in. And some of us aren't people who had like really happy, healthy upbringings. And some of us have. So a lot of us may have adopted some maladaptive coping mechanisms. So when we go out in public, it may not be who we really are. And this was something I had to learn about myself as I started to become a therapist. So if some of you are new, don't worry, it takes time to feel comfortable and be able to just be yourself. And I remember when I first started and I was in grad school and my supervisors would be like, just be yourself, because I would think I needed to be somebody else when I was working with people. And once you find out, what works for you of just being genuine. So it's being able to help the clients feel comfortable with themselves and not being so influenced by outside forces. We'll talk more about that as we go through this. We can go to the next slide. The purpose for the clients is to help them better understand their idealized self versus their actual self. So a better self-understanding of who they are as a person. And this is what I mean of the mask, or presenting who we're really not and being somebody different when you're in your own home when other people aren't around. Is to help lower defensiveness and guilt and insecurity of the people that we serve, to provide positive and comfortable relationships with others, and an increased capacity to experience and express feelings at the moment they occur. So it's not focusing on the past, we're not future tripping, we're focusing on what's going on right now, the here and now. The concept of self. According to Rogers, the self is an outgrowth of what the person experiences, and awareness of self helps a person differentiate him or her from others. So what makes you unique to the person that's sitting next to you? Because we're all unique individuals, we're not all the same. Again, the real self and the ideal self, there is more of the gap between the real self and the ideal self. So being able to look at that and be more willing to look at the maladjustment between who we really are and who we're not. Like I said, not all of us are perfect, but we can learn and practice some different behaviors, which is what we work with our clients to do. And for a healthy self to emerge, a person needs positive regard. So just to feel good about themselves in general. Go to the next slide. Congruence refers to the therapist's openness and genuineness, which is the willingness to relate to clients without hiding behind a professional facade. And so this is what I was talking about when I just started. Was when I first started counseling, I thought I had to be somebody different in the room. So it took me a while to become comfortable with just being myself. And the unconditional positive regard means that the therapist accepts the client for who they are without judgment or disapproving of their behavior, any of their actions or characteristics. So a lot of this really centers on your very basic counseling 101 skills, which you'll see as we continue through the slides here. Empathy is a big one. So this is showing an emotional understanding and sensitivity to the client's feelings throughout the therapy session. So basically, you're really listening and being empathetic to whatever it is they bring to the session to share with you, or into group for that matter. There is no place. So this is kind of a what not to do. Assuming to know what is best for the client. We're not here to tell them what is best for them, or even much less assume that. So there's also the not sharing the assessment and diagnosis results. So when I say there is no place, so when you're not sharing, you're not building that trust and that transparency with the clients. I always ask my clients, especially when they're being seen or have been seen by another therapist, do you know what your diagnosis is? What did your assessment say? So I've been training my staff to be able to have a session after the assessment is over to go over all of that with them so that they understand what the assessment outcomes are, rather than, oh, you need to go to outpatient and you need to attend this many groups, but to really go over it so that they get a good understanding of it. not communicating and not making shared decisions. So this isn't for you to just do whatever you think is best. You need to share those decisions with the client so that they feel that they have input. If you want to build trust, this is very important. You don't want to dismiss the individual's preferences and goals. So they need to have a say in what is going to take place in their counseling. So just teaching them to be assertive and advocating for themselves. And we don't want to foster dependency rather than self-reliance and recovery. So we don't want to get them to the point where they feel like they can't do anything on their own and feel like they have to come to you for everything, but to be able to take what they learn in session and take it out and apply it to their real world. Go to the next slide. We have a responsibility to fully understand the client and family, their strengths, their abilities, what has been successful in their past, along with their hopes, their dreams and needs and problems that brings them in for help. This is to help us create a plan consistent with their expressed values. They're taking into consideration the culture and their wishes. Part of the assessment that we do, and CARF also requires this too, the SNAP has to be in the assessment. We actually include it in a form. And so the SNAP is the foundation of the treatment goals and objectives in the plan of care. So it looks at the patient's strengths, what are their needs, what are their abilities, and what are their preferences. Next slide, please. Strengths and abilities refer to characteristics of the client's life, whatever they've used in the past or present that help them to cope with stressful situations. These can be used in treatment planning to help promote their success in reaching their goals. Sometimes I ask them, what are your strengths? And this also helps me to get a look at their self-esteem. And sadly, I get a lot of people who don't identify. I just love it when they just give me this whole long list of strengths that they have. So helping them find those sometimes is a part of our job as well. Principles, their religious beliefs, their supportive friends, supportive family. They have an ability to go to work, being able to care for others despite their own problems, and to give them, and that they're hopeful. So anything that you can find, maybe it's something you notice as you continue to work with them. If a client has a supportive family member that can be brought into the treatment process with their permission and ask that they help the client with access to medication and transportation. Oftentimes, it's mostly my younger people that come in that are like adolescent or just over 18, maybe grandma brought them or family brought them because they're concerned about them. So I'll ask, is it okay if grandma comes in or if mom comes in? So again, getting their permission to, sometimes that family member that brought them does want to be involved and wants to help. So being able to let them be a part of the process can be helpful. Some examples of abilities. This is being able to take care of themselves, following instructions, and recognizes maybe some side effects of medications. So some of their abilities might be that they listen well, they take care of their daily living needs, they have good writing and reading skills. Again, a lot of people that come in for substance abuse treatment, I've noticed the level of education is quite low. So oftentimes we're making referrals to programs that help them get their GED, that they are able to ask for help, they're open to learn, able to learn, they learn from mistakes, whatever talents they might have, and maybe they're able to save some money. Cooking, they're organized, anything you can think of. These are just some examples. One example is the ability to type. This could be used as a treatment, as a way of asking a client to research information on the internet to help them manage their symptoms. So that they can use a computer. That's important in today's world. And formulating objectives, it's good to ask them about their particular strengths and abilities. Again, this comes from the SNAP that can help them achieve. For example, if the client can save money and wants a car, how can this ability be used to help them reach their goal? This can be included as a therapeutic objective, such as they'll save, this is just example, $5 a month for a driving class or getting their driver's license. Needs refers to the client's problems and symptoms and serve as the basis for goal formulation. And oftentimes I like to refer to Maslow's hierarchy of needs, that pyramid shape, that we want to look at their most basic needs. Some of our people that come into our program need clothes or hygiene products or just something to eat. So being able to connect them with resources is helpful. Maybe they want to learn about their mental health condition. They want to stay in school or get back in school. They want to get a job or know how to get a job. They want companionship, supervision of daily living, services from other agencies. This is where your case manager, if you have one, is able to do a quick assessment and maybe help them get connected to services that can help them, such as transportation to get to their groups, a place that offers some food or some clothing, and sometimes they have needs to be monitored closely at home, depending on what circumstances they have. Next slide. Preferences refers to whatever the client wants in terms of practical aspects of treatment. The following questions might help. If we can accommodate, would you prefer a male or a female? And I've had several females be real specific and they do not want to work with a male. And if they have to, they're like, do I have to? You know, we have to remember some of these people have been through some trauma. Counselor with familiar with your particular culture or spiritual beliefs and or race. I work in an agency where I'm the only Arapaho. I'm from the Wind River Reservation, and so I'm working. The majority of my clients are of the Crow tribe. So I've been here long enough not to say that I know everything about them, but even to this day, I still learn some differences in our cultural beliefs. So it's important that you have. Well, I'm just very thankful for the staff that I have and my cultural counselor that I have so that I can run things by him. If we can accommodate, would you prefer to have your appointments first thing in the morning, over lunch, before 4, after 5? I've had people want to come in but not want to be seen. So, you know, I'm always open to flexing a schedule or allowing staff to flex a schedule to meet someone after hours, just to meet someone's preferences. Next slide. Again, examples, specific programs, appointment times, a therapist of the same or opposite sex. So some people might need other services that we don't have, so we need to be able to refer them to them, such as DUI classes or anger management or more intense psychiatric care. So all of that is taken into consideration when you do the treatment plan, also known as the plan of care. This is your roadmap. The goal of services is the destination, and this is what their vision is of recovery, not ours. What's that going to look like when you achieve your goal? So we can go on to some examples of some goals. Goals should reflect the client's and family's clearest articulation of their destination, their primary reason that they're seeking help and receiving services. Goals should be broad, general statements that express the individual and family desire for change and improvement in their lives. Like I said, sometimes we get the family involved and maybe there is something that they brought that person in for. So sometimes I think it gives the family a sense of, I guess, feeling good about themselves for coming in to get their family some help. Okay. It's often appropriate to have one goal that captures the essence of the individual's and family's needs for their services. So you don't want to have a whole bunch. Sometimes I have them make their own list of things that they want to work on, and let's narrow it down. Let's pick the top three. Maybe these are stuff that they can work on later. Having too many that are too specific can undermine the planning process. So we want to keep it simple, short and simple. Goals are developed from all of the information that you gain from the assessment and understanding from the interpretive summary. The assessment helps identify each individual and family's unique attributes, including needs, problems, strengths, resources, barriers, and priorities in reaching those goals. In the person-centered approach, the clinician's responsibility, so that's me and you, is to help the individual and family identify and express those issues and needs, to help frame the resolution of these needs as goals that are included in their plan of care. Assist the client to elicit relevant treatment goals. Remember, if the client is unable to state their goals, then a family member or the clinician can state the initial treatment goals until the client is able to actively participate. And so sometimes, I might be like, what about if we say this? Or, and I get that and get their involvement. I'll even turn my screen to them. And just recently, I thought about just making like a treatment goal sheet that we can scribble all of this down on, and we can both sign off on that so that they're in agreement with whatever we decide. Because some people, this might be their first time, or they never really even thought, what is their goal? So sometimes they need our help. Some questions to help you with this process. If you no longer had, substance abuse problems, what would you do? If you were not struggling with substance abuse, how would your life be different? I'd like to ask, what would that look like? Is there anything missing from your life as a result of your substance use that you would like to have? Some, it just might be a place to stay, a job, or transportation. And before you started to have this problem, you can fill in the blank. What did you want out of life? So it's being able to help them decide what it is they wanted to accomplish. Some examples: I want to stop fighting with my brother and sister. I want a car, a job, live with my family, stay out of trouble, stay off drugs, have my own place, get the judge off my back. I just want to get along better. And this is an example of a parent's goal. I want us to get along better. And Jamie will engage in the therapeutic process. So this is not this person's goal. This is someone else's. So you want to be able to, I tell my staff, put it in quotes so that this is in their words as best as possible. Although these goals are not treatment or disorder specific, they are affected by mental illness. Recovery and rehabilitation are concerned with helping people lead their lives to the fullest potential. So being the best person they could possibly be. Rehabilitation helps people restore their lives to their former level of functioning. Next slide. And then here's some objectives. These are the changes necessary to help the client. They help identify the immediate focus of treatment, are incremental tasks. So steps that the family will focus on little by little as they work towards that goal. That's why when they say when you want to achieve a goal, you want to break it down into little pieces. So this is the steps known as objectives. The focus of objectives is the removal of barriers. Ask the family or client what's keeping him or her from reaching the goal. These barriers become objectives that are the focus of treatment. So maybe they're using substances as keeping them from keeping a job, getting a home. Basically, I see people that mostly have nothing. Go ahead to the next slide. They need to be action-oriented and use behavioral terms. Historically, we focused on the process over the outcomes. So we see many objectives written as client will gain insight, have understanding, and be able to accept. That's historically. Next slide. Objectives are typically action words, so they need to be behavioral, they need to be specific, and they need to be measurable. So I'm all about using the Likert scale in almost everything I do, unless we're using a specific assessment tool and we're just looking at seeing an increase in a score. Objectives should state the desired changes in behavior. Occasionally, it may refer to the identification of triggering factors. In such situation, target dates should cover no more than 2 or 3 sessions. So you don't want to have this something be like long-term. And in my personal experience, very, very, very rarely do I get natives that come to counseling pretty regularly. I get a few now more than I ever have that are really interested and keep coming back. So so if you keep it short and simple, it gives them something that they can accomplish and feel good about themselves. Achieving objectives usually requires the client and family to master new skills and abilities that support them in developing more effective responses to meeting their needs and challenges. A properly written objective typically begins with the client and family will and describes the desirable, significant, or meaningful change in the behavior, status, or function as a step toward reaching the larger goal. The next slide, please. Some key features, again, they need to be reasonable. They need to be measurable, appropriate to the treatment setting, achievable, understandable to the individual, time specific, written in behavioral specific language, responsive to the client's needs, disability, disorder, challenges, and stage of recovery, and appropriate to the client's age, development, and culture. Objectives should be SMART. That's another acronym. Simple, specific, straightforward, measurable, achievable, action-oriented, reasonable, and set a target date. Okay, measurability is intended change should be obvious as readily observed by the client and family as well as the clinician. It's acceptable measure change by observation, self-report, completion of an assignment. Sometimes you give them a list of things that they need to go and accomplish on their own. Other measures are standardized tests, drug screens, journaling, behavior charts, our diary cards, anything you can use that can measure their progress in achieving their goals. Strength-based approach is also a part of this. Objectives should describe positive changes that build on past accomplishments and existing resources. Objectives should reflect an increase in functioning and ability along with attainment of new skills rather than merely a decrease of symptoms. So, for example, I did have a client who wanted to get a job and boom, she got right on it and got a job right away. And she's like, oh, now we have to change her schedule because she got that job. So, look at you. You went out and did all of this stuff yourself. That's just great. You were able to go out and do that for yourself. So sometimes our job has some really good things that we get to witness. Achievability, your objectives should be realistic, developmentally appropriate, and culturally appropriate, and reflective of the client's strengths and limitations. Next slide. Attendance and participation can be a part of it. Phrases such as Bill will participate in medication group weekly, or Gail's mother will attend family cycle education groups. Those are not objectives. Mere participation in no way indicates that skill development or behavior change occurred unless this reflects the level of motivation and engagement. So We don't want to focus it on just their attention. Your objective should focus on what the individual and family is going to do differently and focus on the actual demonstration of new skills and abilities. Like I said, for example, the young lady that went out and got herself a job. And people that work that are in recovery actually do better than those that don't. So, that's a fact. One example here, I want to get along better, the mom's goal. The context here is the son who's 16, defiant when his mom speaks to him. He's always rude and talks back. And this happens every day. The objective is Mom and John will spend 5 minutes each day only talking about the day's events. So eventually that 5 minutes is going to go longer. And sometimes I actually change this objective to they're going to spend a certain time where they actually engage in those dysfunctional behaviors. And it's kind of what I refer to as reverse psychology. Some common mistakes when writing learning objectives is describing what the clinician is expected to do instead of what the client is going to do, including more than one expected behavior in a single objective, forgetting to include all three components of a learning objective, so condition, performance, and criteria, using terms for performance that are subjected to many interpretations, not action-oriented, difficult to measure. So they need to be specific and clear. They need to be able to understand exactly what it is they're shooting for. Some common mistakes. Did we skip a slide? Okay, go ahead. Sorry. More is writing an objective that's unattainable, given the level of ability of the client, writing objectives that do not relate to the goal, cluttering an objective by including necessary and unnecessary information, being too general, not clear, using general verbs such as understand, demonstrate, discuss, participate. That's a little vague. Go ahead to the next slide. 5 conditions required for therapeutic change are the client's psychological contact, the therapist and client. So the whole thing of person-centered therapy is that relationship between the client and the therapist. That in itself is the person-centered therapy, like they need to have that relationship. Client incongruence, again, I talked about this in the early, as I gave you a brief definition. So there's that incongruence between their experience and awareness, which can cause them to be vulnerable and anxious. So just helping to get them to understand themselves a lot better, who they are, and their preferences and needs. The therapist's unconditional positive regard is probably the most important, and we should do this with all of our clients. That's why I say this person-centered therapy really is your very basic counseling skills. So this is just us accepting those patients unconditionally, not judging them, and just being happy to see them when they come into group, and having empathetic understanding and the client perception that the client perceives as to a minimal degree the therapist's unconditional positive regard and empathetic understanding. So they need to be able to feel that relationship with that person. And I just love it when clients come in unexpectedly and they might be having a situation at our office, but they want their therapist because they want to they feel comfortable with that person. So it's good once you know that they're building that relationship with that individual. Next slide. Process of therapy, clients' communications about externals and not self. So they may be talking more about what's going on out there and not what's going on right here. So we need to bring them sometimes to the here and now. Client describes feelings but doesn't recognize and own them personally. They may be having some problems with maybe an employer or a family member, but they just want to vent about them, but not taking responsibility in that of what's their part. And part of me is helping them understand what do you have control of and what you don't have control of. So it's being able to deal with that situation on their own, Client talks about self as an object in terms of past experiences. Client experiences feelings in present, just describes them with distrust and fear. Next slide. Client experiences and expresses feelings freely in the present. Feelings can bubble up, so it's good for them to get that out. Client accepts and owns feelings in the immediacy and richness. Client trusts new experiences and relates to others openly and freely. And I've actually had some just not want to come to group at all. So sometimes our whole process with them is just to get them to start to feel comfortable with that. The therapist should listen and try to understand how things are from the client's point of view. Check your understanding with the client. If you're not sure, you know, it might be, so this is what I'm hearing. This is what I understand. Treat the client with the utmost respect and regard. There is also a mandate for the therapist to be congruent and transparent. So you don't want to be hiding anything from the client. You need to be open with them. Next. Focuses on the quality of the therapeutic relationship, serves as a model of a human being struggling toward greater realness, is genuine, integrated, and authentic without a false front. So like I said, just be yourself, who you really are, and openly express feelings and attitudes that are present in the relationship with the client. These are your very, very basic counseling skills. Listening, really listening, accepting that person, respecting that person, understanding what it is they are sharing with you, and being able to respond. What I like about this person-centered care, and it makes perfect sense to me why CARF, an international accreditation agency, would require it, is this is perfect to use with a broad range of people. Like I said, we're using it here on the Crow Reservation with mostly Crow clients that come in, and it's going very well. It could be used with people with schizophrenia, people suffering from depression, anxiety, substance use problems, cognitive dysfunction, and personality disorders. Can be used in individual, group, and family therapy. There's no strict guidelines as to the frequency. We usually keep it to 1-hour sessions about once a week. Scheduling can be adjusted according to client's needs. Termination occurs when the client feels like they're okay and they're good enough to manage problems on their own. Some expected results you'll see is self-esteem improves, trust in their own feelings and experiences is valuable sources of information to make decisions, increased ability to learn from their mistakes rather than repeating them, less defensiveness, guilt, and insecurity, feeling more positive and comfortable in relationships with others. Like I said, I've had people not want to go to group, eventually look forward to coming to group. An increased capacity to experience and express feelings at the moment they occur, and openness to experiences and new ways of thinking about life. Here's some specifics to natives. This is a survey that I found. I was trying to do some research. I like to do research, and I was a little disappointed because what I found is pretty outdated. And this survey that I'm sharing some information from was from the therapists that were interviewed. So this just says, what should counselors do in the first session to build rapport with native clients? Clients should be welcomed warmly and offered refreshments such as water, coffee, tea. Paperwork should be minimized. Clients should be invited to describe the problem or issue from their point of view. The counselor should use self-disclosure to elicit client talk. The counselor should be sure to address the role of culture in the client's life. In our electronic health record system, we have a Native American assessment scale, and it looks at a lot of their culture so that we can decide if this is a person who wants to have more cultural activities or spend time with our cultural counselor. Counselors should talk about confidentiality and expectations for counseling and let the client determine the content of the counseling sessions. Another one is, are Native American counselors more effective with Native clients and non-Native counselors, or is there no difference? And some of the respondents in this particular survey I pulled up, half the respondents said that Native counselors are more effective than non-Native, 20% said there's not a difference, 18% said it depends on the cultural competence of the counselor, and 12% said it depends on how traditional the client is. I did another presentation, gosh, several years ago when I was in my doc program, and I did a presentation on ethnic minority help seeking. And the one specific to Native Americans did say, and this was of college students that were surveyed, and there was a real strong preference for Native counselors. So we really are needed. And when I was talking about not being able to find research, it's because there's not Native people out there finding it. A lot of, when I do find research, a majority of it is not even done by Natives, it's done by non-Natives. So we need more people out there. What is the most significant barrier that prevents Native Americans from getting counseling? Many respondents said stigma, mistrust, or fear of being judged as a barrier. Other barriers identified were lack of money, shortage of providers, long wait lists, dysfunctional systems of care, racial discrimination. Presumably, the respondents based their answers to this question on their professional experience. Again, this is from counselors. And here where I'm at in Crow Agency, I found out that the mental health services at the Indian Health Services was basically non-existent for like 2 years. And now they finally have it going, and they only have like 2 counselors. And so when I refer people, my clients don't get in right away. So I'm so happy that I hired a certified counselor so that we're able to get more of our clients the services that they do need. But there really is a shortage of therapists out there, especially where I'm at. Next slide. What should counselors or counseling centers do to make Native American clients comfortable, getting them used to the idea of getting counseling? One of the things that I've included, I restructured my program to, instead of going by how many sessions, we go by how many hours of treatment. And so if they add a week of individual counseling, that gets to add to their hours as well. So some of them have actually been signing up and attending their sessions regularly, which is really good to see. So other than that, making the environment more welcoming, having Native art on the walls, providing refreshments. It's a common cultural thing, you know, people come to your house, you want some coffee, you want something to drink. Next slide. What should counselors, non-Native counselors, do to improve their understanding? They should really get involved in the community. The director of the behavioral health here is not Native, but she lives in Crow Agency, and she's been working with Natives for several years. I think she came from South Dakota before she started here. And I can just really tell, I meet with her quite often and we have lunch, and I'm just amazed at her level of cultural competency, and that she's, you know, she lives here and participates in a lot of things in the community. So getting to know the elders. For myself, I have a cultural counselor on board. I am so glad to have him. Like I said, I'm not Crow, so I have to be mindful of not doing anything that I shouldn't. And you know, some of the people here attending training and workshops to socialize with Natives. I actually have like a couple of presentations that I do mainly for non-Native counselors to kind of teach them the basics. Next slide. And that brings us to the end of my session today. So again, this person-centered therapy focused on the client's present conscious problems, in which it is assumed the client is the primary actor in the curative process. So they need to take the lead, and the therapist is just the facilitator. You're not there to solve their problems or tell them what to do, but just to be there to listen and give them some guidance. We have any questions? I've been seeing the chat box has been popping up. Is there anything there in particular I missed? Any questions?
Yeah, if anybody does have a question for Avis, and thank you, by the way, Avis, please just unmute yourself. We have a couple spare minutes, so go ahead.
Everybody's quiet.
Hi, I was just wondering if you think that there could be opportunities for our client to become like a co-leader in some of the sessions? Or would that be beneficial, do you think?
Well, we have peer specialists now, and I just love them because these peer specialists come from where my clients work, because I'm doing substance abuse treatment right now. And they actually really like those peer specialists because in this community, they know who that person was in the past. So they're like, and they sometimes I step in and cover group because my counselor needs to be out for some reason. So I often step in myself, kind of just to check things and see how things are going. And it's good for me to hear the client say, "Where's so and so?" And then they talk about how much they really like that person because they see them as a peer and not as someone that they don't have a relationship with. So I always like to encourage those that are in recovery to seriously think about going the peer specialist route. And we have a girl who's actually an intern with us now. And she was a client there. I was told by the staff that were there before me that she was a client before, but she went to college and now she's coming in to intern. So she's going through the process to somebody who actually was successful in her outpatient treatment programming. So she's very excited to work with the people. So not necessarily get the participants themselves, I would say, but I would say someone who is a peer specialist who can actually speak from, and on the reservation where I'm from, they use a lot of the peer specialists to be co-facilitators for large groups. And it was really effective for me.
Do you think that it would benefit your clients if you had some kind of items on your desk that they could fidget with and or possibly do a craft while they're sitting there? Because I know that at my house, we have stuff on our table that people can pick up and play with, and they don't have to focus their eyes on the person, but they better listen when they're doing something with their hands.
Exactly. I'm glad you brought that up. When I did a trauma therapy presentation, I get these little, they're usually in party favors, these little cans of Play-Doh. They're little tiny cans of Play-Doh, pipe cleaners because they're fuzzy, and those little squishy balls. You can get coloring book pages and some color pencils and just leave them. We leave them out all the time, and markers. So if they want to doodle and draw while they're there, that's perfectly fine. I have just been talking. In my last office that I had my own sand tray, and even my staff would come in and they'd be talking to me and they'd be playing in the sand tray because I had those little rakes and stuff that you could make designs and stuff in. So those are awesome ideas to implement them in so that they're more comfortable. And my experience with that has been, especially people with trauma, it does give them something else to do while they're participating, but they are participating. I think it's a great idea.
is that something that you would possibly teach when you are training someone who's not familiar with the culture?
You know, I never brought that up. I do talk about doing some art activities, and how we do that here is just by having a cultural group where the clients can come in and bead or sew or just do their art. We have some clients, and I see this a lot wherever I go, and I'm working especially with natives. Some of the men are some of the most amazing artists that you encounter. And that, you know, that is a strength for them, I believe, that if somebody really focused on it, some of these people's artwork is impressive enough that I think, you know, they could sell their art.
Anybody else have a question for Avis before we wrap up? Okay, well, so let me take this opportunity to remind everyone that it is Native American Heritage Month this month and Veterans Day on Friday. So like I said before, you will have access to these slides in your follow-up email that we'll send out. And then our recording will be on our YouTube page. If you need to refer back to any of this, please take our evaluation survey in the chat if you wouldn't mind, so we can continue to provide these free of charge for everyone. And I guess just thank you, Avis, for all this helpful information. These are great questions that people have at the end. And I'm glad we had time to allow that today. So take care, everyone, and it's good to see you. Until next time in December, second Wednesday of the month, we will have Mike Bricker on from the STEMS Institute. Okay, so it's good to see you guys. Thank you. Bye-bye.